thanks for having me. My name's Channing, and I'll be presenting joint work with Mathieu Chemin and Johannes Haushofer. The name of our paper is called Health Insurance Reduces Stress, Evidence from a Randomized Experiment in Kenya, which is probably the least interesting title of the entire conference. So we've given away the intervention and the results already, but I'm going to spend the rest of the time trying to convince you why you should care. So I think the natural question for economists is, why is stress important? Why should we care about stress? And I've got three reasons that I'd like to tell you why it actually is important for economists to study stress and try to reduce stress. So first of all, let's think about psychological well-being as a more broad indicator of welfare. I think each of us individually are aversive to stress. It correlates with unhappiness, and it should be something that we care about if we're thinking about multidimensional measurement of poverty, is psychological well-being. The other thing that stress really correlates very strongly with is depression. And depression, we know, has very high economic costs. It affects about 350 million people worldwide. It's a second leading cause of disease burden, and it's projected to be number one by the World Health Organization. And some estimates put it about 1% to 2% of GDP in terms of costs. The last reason why we should care about stress is that there's a small but growing literature that looks at how stress causally affects economic choice. And these are recent experiments that are done in lab settings, but they show that by manipulating stress, we can change things like risk preference and time preference. So as economists, we should really care if stress may be one of the primitives that could drive economic choice. So I hope that I've convinced you that we should care about stress, and now I'm going to tell you how would we reduce stress, all right? So what are some of the ways that we could reduce stress? We think back to the very early literature on stress that really links stress to controllability. And if you read these papers, what they actually did was literally shock people with electrodes that were controlled or uncontrolled. So the analog to this in the economic domain might be something like an economic shock. So if we think that controllability of shocks can reduce stress, how can we control economic shocks? And we do that with insurance. So here in this paper, we investigate an intervention of insurance aimed at smoothing economic shocks. We want to look at a variety of outcomes, including health, subjective well-being, self-reported stress, and cortisol. So a quick note on cortisol, it's the body's major stress hormone. It correlates with depression, stress, poverty, and we measure it in salivary cortisol. And finally, another addition that we make is that we use a cash benchmark arm to really isolate what I'll call the peace of mind effect, or the insurance effect, from the insurance specifically, to disentangle that from the fact that we're giving someone a policy that's worth a certain amount of money. So by benchmarking with cash, we can really isolate the effect of insurance alone. So how does this happen? We have a very quick conceptual model to walk through with you to show you how this really isolates the effect of insurance by adding this cash benchmark arm. In this world, we've got income, a probability of an accident, the cost of medical treatment, insurance premium, and a benefit paid by the insurance company. So in expected utility, if you have no insurance, you basically face this utility function where you have your probability of accident, and if you experience the accident, then you have to pay this cost C here. On the other hand, if you have insurance, you pay an insurance premium I in both states of the world, but in the state that you suffer an accident, you have to pay the cost of the medical treatment, but you get reimbursed or insured by the medical company, or by the insurance company, and you get that benefit B. So these are the two states of insurance and not insurance. So in our experiment, we have two arms. We have an unconditional cash transfer arm here, where we give people I, the value of the coverage of insurance, in terms of cash. So they get I in both states of the world. In the case that they are injured or suffer an accident, they don't get B, but they still have to pay C out of pocket. So in the insurance arm, on the other hand, they don't have to pay I, so there's no negative I in this term because we give them the insurance for free. And if they suffer an accident, they receive B from the insurance company. So if I just add and subtract I from each side of the insurance equation and subtract them from each other, we actually can recover the average treatment effect of insurance estimated at a Y plus I. So not estimated exactly at Y, but at a slightly higher marginal value of Y plus I. So what we'll claim is that this really can identify this effect of insurance by controlling for the income effect that a lot of other experiments have, where they give people insurance and they have a pure control that actually that insurance is embedded with some value. So here we can control for the value of that insurance. Okay, so the experiment, the context is in urban Nairobi in the Kamakunji district, the Juwakali Association, they make metal things. So they make pots and stoves and boxes. It's a very chaotic and quite dangerous environment. They're using hand tools and welding without protection, and accidents are not infrequent. We run a randomized field experiment with around 800 people into the arms that I mentioned earlier. So first I'll talk about the insurance, which we teamed up with the CIC insurance companies to give people an Afya Bora plan. It provided a 1-year cover for both inpatient and outpatient services, covered chronic and pre-existing conditions, and it covered the respondent and up to 5 dependents for 12,000 shillings, around $300, but we covered their entire family. So if they had more than 5 dependents, we would pay the extra money that it costs to cover the entire family. So in the cash transfer arm, what we did was we calculated the value that it would have cost, either 12,754 shillings or slightly more if they had a bigger family, and then we gave that to them via cash transfer in M-Pesa. So one quick note that I want to caveat some of these results with is our sample, because of miscommunication with our data collection, with our field collection team, we have differential attrition at end-line. So to control for that, we found one of the variables, which is whether or not you had an ID at baseline, strongly predicts attrition, and by restricting our sample to only those with an ID, we can get the attrition problem down to 14 individuals. So this is the results that I'm going to present, but in the paper we do a number of robustness checks and we do a number of bounding exercises to try to convince the reader that the attrition, although it is differential, does not cause a problem to identification. So here's a quick project timeline. The blue is when the baseline surveys took place in early 2011. The big masses of the red bar and the orange bar is when the insurance date started, and then when we actually sent the cash transfer, and then here you can see the end-line survey was roughly a year later. So our econometric strategy for this is quite simple, bounding and robustness aside. We estimate very simple OLS with our outcome variable Y. Beta 1 and beta 2 will give us the treatment effects for the insurance and UCT arms respectively. We have baseline levels of outcomes where possible to add power, and a vector of controls. We also will look at some heterogeneous effects, and this is very simply crossing these treatment dummies with the interactant of interest, which I'll get to later. So recall the main research questions are what are the effect of an insurance provision on decreasing stress? And then the second kind of question that we can answer is, do interventions aimed at different kind of poverty alleviation? That's reducing variability in income or in economic circumstance, or just giving someone a cash transfer, do those have different differential effects on well-being? So let's jump into the results. So first let's look at subjective well-being. The way to read these tables are the outcome variables are on the left side, and then the independent variables are across the top. So columns 1 and 2 are from the same regression, reporting the treatment coefficients of insurance and UCT versus the pure control respectively. Column 3 looks at the difference between those treatment groups. So it says if those differences are statistically significant from one another. So first we have with controls and without controls, and you can see that stress is reduced in the insurance group, not in the UCT group, the unconditional cash transfer group, and that difference is significant. So looking at other measures of well-being, optimism, self-esteem, depression, locus of control, etc., we see not a lot of other movement here. So maybe some evidence that the unconditional cash transfer increases the locus of control, but the difference between the cash transfer arm and the insurance arm isn't significant. So we see reductions in stress and self-reported stress. Do the reductions in self-reported stress coincide with the reductions in objectively measured salivary cortisol? So here are the results, one of the results on cortisol. We take the log average cortisol level of the 2 cortisol samples that we take during end-line. And you can see that there's a large and statistically significant reduction in cortisol levels in the insurance group, again, not in the UCT, and that difference is significant. And this is true with and without controls. So because cortisol is a very messy measure, a lot of people will clean the data in lots of different ways. So a very typical thing to do is to regress out the residuals, such as when you woke, if you ate or drank, if you're a smoker. You'll also truncate the data, or you'll Winsorize the data. So for completeness, I'll report all the results here. They're essentially unchanged, except sometimes the difference between the insurance and the cash arm is no longer statistically significant, but the point estimates are all very, very similar, and it goes with the story that insurance reduces both self-reported and self-reported stress and cortisol, while the cash transfer does not. So does insurance give peace of mind? So I'm talking about this peace of mind effect. And the thing that really would drive this peace of mind, what we were thinking about is, it's not about the insurance is covering you and protecting you from a shock. Whether or not you actually receive that shock shouldn't matter if you're thinking about peace of mind. So we should see that these results go through for those that use the insurance, and also for those that don't even utilize the insurance, right? Just knowing that you have the insurance should be enough to reduce your stress and reduce your cortisol. So I'll caveat this with selection, right? These people, over the course of the experiment, either endogenously choose to utilize the insurance or not. So I wouldn't take this as a pure result, but take this as like evidence to support the fact that it might be working for those even that don't necessarily need the insurance. So we can see cortisol goes through it in exactly the same way. In fact, maybe the point estimates might be even better for those that don't make any claims on their insurance. All right, so I'm going to talk a little bit about heterogeneous effects now. So the question for me that drove my analysis of the heterogeneous effects are trying to understand if the effects go where the peace of mind might be the strongest. And where might that be? So I'm positing that it could be that when the more economic volatility is covered, so that's if you have a larger family or if you have children, you might get a bigger peace of mind effect because you're protecting not just yourself but your entire family. When health shocks are more severe, so if you're poorer, the cost of the treatment is going to be more costly for you. Or when the baseline probability of the health expense is higher. So if you remember our framework, it depended on that probability P of suffering an accident. If you have baseline lower levels of psychological or physical health, we might expect that you might value the insurance more. So here are the heterogeneous effects. So you can see the interactant is across the top. We're looking at the outcome is log average cortisol. The interactant is across the top here with below or above median income. Whether you were sick the month before baseline survey, not end-line survey, baseline survey. Whether you have any children at all, and if you're above or below the median CEST, that's a depression screener. So here we see that the point estimates are very much in line with what we would expect. We see larger reductions in cortisol for those that we might expect to benefit more from more peace of mind from the insurance. It's statistically significant for those that have children versus those that don't, and those that are more depressed versus those that aren't. The other ones don't go through, but I think it adds some more flavor and color to where this peace of mind effect might be the most beneficial. So this is a quick slide to contextualize the effect of what we found to other studies in the literature on cortisol. So we found a 0.13 log nanomole reduction in cortisol. The two cash transfer schemes that also measured that were Johannes' early paper with Jeremy on the Give Directly UCT and a Progressa cash transfer, that we found very similar results to those. Those were cash transfers where ours were insurance. And the reason why we might not have seen the same effects for our cash arm is because the size of the cash transfer was much smaller. It was less than half the size compared to the Give Directly unconditional cash transfer. We also see very similar levels of standardized reductions in stress to cognitive behavioral stress management interventions that are targeted specifically at stress management. So our insurance treatment was able to get close to what an actual stress management treatment can do. So in conclusion, we find that insurance, but not the equivalent cash amount, decreases stress and cortisol levels. We find some heterogeneous effects. Those that have children and those that have more severe depression benefit more from this reduction. And we find no effects of insurance on health status or healthcare usage. This is very much in line with the literature on evaluating health insurance. And we claim that this comes from the peace of mind through consumption smoothing. There are some other papers that look at health insurance that show that there's a large reduction in catastrophic costs. So in our mind, we believe that the channel might be through people knowing that because catastrophic costs are covered, they're a little bit more at ease. All right, thank you.
Thanks, Jenning. I'm not sure how to make this full screen here. Okay. I really liked reading your paper. I think it's very interesting and important. I have some comments, of course. The first one is actually about something that you haven't talked about at all in your presentation, which I thought was very prominent in the paper. Namely, you say that there is no evidence that health insurance reduces or improves health status. And this is also the reason why you don't put this in the utility function. I found this very, let's say I didn't agree with this because context is key. So first of all, in the papers that you quote in your paper, the question is, how good is the quality of care that people can use with insurance? Is the measure of health self-reported, or is it objective? And also, is the time period of the experiment long enough to see any improvement? Now, I know of one paper that does show positive effect on objective health status, and it's this one by Hendricks et al., published 2 years ago, namely that health insurance reduced measured hypertension significantly. My second big point is about whether you really eliminate the income effect by your setup. And what I've done here in this table, I've written down all the differences that I could see between the two treatments. And the first three ones, the first three, namely the duration, who is the recipient, and also what is the anchor of income, I think that they all have something to do with income, let's say. So for example, the duration, having insurance for 12 months means that when you get sick, you get reimbursement for that, right? Whereas getting the cash transfer once doesn't work like that. And also the recipient, you didn't also stress this in the paper, but I think that almost everyone is male, or like everyone is male in the cash transfer arm, whereas in the insurance arm, it's the family that receives the insurance. So the income effect is for different people, let's say. And the anchor, so you rewrite the utility function by saying u of y is equal to u of y plus 1 plus I minus I. But because of loss aversion, I don't think that you can really say that. And I'll send you my other comments by email, so I'll leave it at that.
Great. I guess I can answer here. So yeah, that's great. Thank you for that. The papers that we look at in the literature, I agree with you. There's a number of differences that our insurance has from the literature, and we don't measure nearly to the extent that other people do, right? We don't take the same kind of hypertension things and objective measurements that others do. But we found, so I think the Backer paper on the Oregon Health experiment is a good example where self-reported, like how they self-reported feeling went up, but the objective measures actually didn't change. So there's a lot more contextualization that needs to take place. I totally agree with you that we might not expect it to be the same in this setting. So that's a very fair point. The discussion about, removing income, I think that's also a very good one. I wouldn't want to confuse what I'll call a conceptual framework with a model of utility, which I think it's just more of a way to think through how the comparison happens. The duration comments, I think the reason why we decided to give a one-time transfer was we wanted to see if anyone actually internalized the fact that the insurance was valuable, right? If we gave them the same amount staggered over 12 months or so, then they wouldn't actually be able to afford the insurance product. As it turns out, no one actually bought the insurance, so no one in the cash group bought the insurance, so that is less of a problem. The recipient is true, depending on, again, your feelings about the unitary model of a household. And I totally agree with prospect theory, like integrating loss aversion, integrating the health, and that's why I think more work could be done in maybe quantifying where that peace of mind piece might come from. So I think those are really good comments, so thank you. Questions?
So I didn't understand what you mean by you give people insurance in the form of cash transfer. Because is that the premium? Is that the... So that's not really clear.
Yeah, sorry. So what we did in one group, we gave them an insurance coverage. So they just got a one-year plan. In the cash transfer group, we calculated what that plan would have cost for them, and we just gave them the cash instead. Yeah, so it was just, no, so it wasn't the value, it wasn't the calculated value based on the loss probability. It was actually just the value of the insurance coverage. So how much would it cost to cover that family for a year? We then gave them the cash instead to do whatever they wanted, right? They could buy the insurance or they could do whatever else they wanted to do with it.
Yeah, but the thing about insurance is that when you pay a premium and if you get a shock, then you get some, you're depending on the loss that you have, the insurance covers it, right? So it's not the same as giving someone the premium.
Absolutely, yeah,
premium.
absolutely. I agree. You might argue that in expectation, if these are actuarially fair and we're randomizing, then it should be exactly right. I don't think that's true in practice, but I think that's the general idea, is just to get closer to that benchmark. Okay. Usually when you give someone insurance or a control, you forget about the fact that you also gave them something. So we're trying to balance, benchmark it with cash a little bit more.
Okay.
Okay. Great. Thank you, guys. Oh, yeah.
I mean, it's really interesting. But you don't give people any sort of information to the cash transfer. You just give them money, but you don't tell them that there is insurance available, or...
Exactly. So there is definitely an information thing, right? We found that about less than 5% of the people at baseline had insurance anyway. So there's also some effect of just knowing that insurance exists. It's hard to say if they didn't know or if they knew beforehand. One thing to note is that we know now, after the one-year coverage is over, I think nobody renewed their insurance. So it's an interesting question about, although we saw results on stress, did they not value it? Did they not realize that those existed? So yeah, it's interesting. Okay. Thank you, guys.
Hi, I'm Zoe McLaren at the University of Michigan, and this is joint work with Anne Fitzpatrick, looking at the impact of stockouts in the public sector on private sector outcomes. And we look at the anti-malarial market in Uganda. So we know that developing country governments put a lot of effort into increasing access to basic health care, reducing or eliminating user fees, improving supply chains, but there is still pretty high frequency of drug stockouts of essential medicines, kind of a short list of essential medicines. When there's a stockout in the public sector, and in the public sector often these medicines are available for free, patients are either going to turn to the private health sector, which is reasonably unregulated in a lot of countries, or they'll fail to seek care. They won't be able to afford the out-of-pocket costs or the travel costs or things like that. And we're concerned that there may be negative impacts on their health outcomes. So a stockout in the public sector may mean that they have a treatment interruption. It may mean that they fail to get treatment at all. And then this could impact, in terms of the out-of-pocket costs that they require, the opportunity costs of traveling to a different location, to the private sector to obtain care. And it may have impacts on equity if more vulnerable populations are are more heavily impacted by stockouts, have fewer outside options. And so one of the reasons why we want to quantify the impact of stockouts is because they're preventable with, there are a number of kind of straightforward interventions on supply chain side to improve, improve supply chains, and that they're kind of quantifying the benefits of those types of interventions. You need to have an idea of what happens when there are stockouts. We're going to look at stockouts in the context of malaria in sub-Saharan Africa. It's the third leading cause of morbidity and mortality, and children under 5 are especially at high risk of death. ACTs are currently the only effective antimalarial due to drug resistance, but they're relatively expensive, especially compared to the other other malarial treatments that are no longer really effective in most places. And Uganda has the highest burden of malaria in the world, and I apologize. The map on the left is a map of the world with the countries inflated to represent the burden of malaria, and the inflation confused me a little bit, and that's Sudan that's located in that box, and Uganda's like slightly down and to the left. So it's darker color, a higher burden of malaria, but a smaller population, smaller country, and therefore not as big of a overall burden, but it has the highest burden of malaria in the world. So our research questions, we want to know what the welfare impacts of stockouts are, and we're looking at how this reduced competition from the private sector is going to affect outcomes in the reduced competition from the public sector is going to affect outcomes in the private sector. We want to look at, does it change the prices that are faced by consumers, the quality, the types of drugs that are dispensed for malaria, and then the composition of the consumers, who's getting access to care in the private sector. And then we also want to think about what are the implications of these stockouts and these changes for health outcomes and patient welfare overall. So despite the frequency of stockouts, there are very few studies that look at the impact of stockouts, especially in sub-Saharan Africa. So we're one of the first studies to do this. And we focus unusually on this mechanism, these spillover effects from public sector stockouts into the private sector. And it has some implications for the regulation of private sector markets. And then we also measure drug quality very accurately using a spectrometer to look at the actual active ingredient composition of the drugs. As a quick preview of our results, we find that when there are more likely to be stockouts, private sector prices increase by about 14%. We find no significant difference in terms of the quality of the drugs that are being dispensed. We do find differences in terms of the composition of private sector customers, that the poor and the least educated seem to drop out of the market. So these are likely patients for whom stockouts in the public sector mean they won't get access to care at all. We're using primary data collected by my co-author and her team in 2013 on drug markets in 114 villages in Uganda. So first of all, we have a census of all drug, private sector drug outlets within randomly selected parishes, those are small areas in the country. We also have a private sector survey that includes both vendors and real customers to get information on the shop operations, inventory, and the demographic characteristics of these vendors. And then also as a third layer of data, we have mystery shopper data. So we sent people with kind of randomized scripts into these different drug shops to collect data on prices and the type of care that they received. And then from the mystery shopper purchases, we do spectrometer measurements of the quality of those drugs. So our identification strategy, how we're measuring stockouts, we don't have actual data on whether or not there was a stockout. So what we do is we know that drugs in Uganda are delivered from a kind of centralized warehouse to these different facilities in the public sector on a preset schedule. So every 2 months there's a scheduled delivery. And so we use these preset dates as a proxy for the likelihood of there being a stockout. And so we can kind of look at the price and quantity and quality of drugs sold in the private sector kind of immediately before and immediately after these scheduled delivery dates. And that there are very occasionally emergency shipments, but they're very rare. And in general, these shipments are just, they're on a schedule and they don't respond to the needs of facilities or populations. We also control for kind of small area fixed effects as another way to address confounders. So our empirical strategy, we run linear regression. The public health facility dummy is for a village that has a public health facility within it. It's going to be kind of a measure of exposure to potential stockouts. Our likely stockout dummy is for data that's collected before the scheduled delivery date when there are more likely to be stockouts in in that market. And our outcome Y is measures of prices and quantity and customer characteristics. We have parish fixed effects, as I mentioned, and we also have controls for the market concentration in that village, the type of private sector establishment, so whether it's a clinic or a drug shop or a pharmacy, and then the characteristics of our mystery shoppers, just as additional controls. And we cluster the standard errors at the village level. So this is our data on the relationship between the delivery date and stockouts, and you can see that in the week before the scheduled delivery date, the fraction of facilities that have a complete stockout of antimalarials is about 5 percentage points higher than in the week after. So this data is not collected at the same time. So our primary data was collected in 2013. This data is from 2015. But we have no reason to believe that the relationship between the likeliness of likelihood of stockouts and the time relative to the delivery date would differ between these two periods. There may be some concern that there's kind of hoarding of ACTs, but the issues with that is that the kind of need for ACTs are uncertain. No one knows when they can have a good prediction of when they'll have a bout of malaria. The need for the ACTs is immediate. When you're diagnosed, you need to be treated quite quickly, or it kind of risks higher costs of the disease. And then because it's expensive, it's really costly for patients to hoard malaria medication. So to get into some of our main results, we find that when there are kind of in the period when those stockouts are more likely, in areas where there is a public health facility in the village, that private sector demand rises. So you can see of the interaction effect here. So private sector demand, the market share goes up by 18.3 percentage points in that period right before delivery in facilities in private sector establishments in villages that have a public health facility within them. We also find that kind of alongside this increase in demand, prices that are charged by the private sector increase. And there is a fair amount of bargaining that goes on in these shops, so we do think that prices would be very responsive and easily adjusted. So the price paid goes up by about 46 cents for a kind of unit of drug, which is about kind of 14% increase. The profit margin also increases, and we also find that there's increases in the variation of prices paid for the same type of drug, and we think that this is kind of a measure that represents reduced welfare for customers. They can kind of go to the drug shop and not have a good sense of how much what those prices are going to be, whether they'll be able to afford the drug itself. We expected to find potentially a reduction in drug quality. This is one of the things that private sector firms will often do in response to kind of increased monopoly power, increased demand, but we find that although our point estimates generally go in the direction we expect, nothing is statistically significant. So we examined whether or not the drugs were substandard, so that's based on the spectrometer active ingredient measure, whether they bought a drug that's ineffective, so those are kind of those non-ACT drugs, whether they have the incorrect dosage, so a child dosage for an adult patient, whether too few tablets were given, so kind of 2 out of 3 doses instead of the full set of doses, and then we also have an index of drug quality. None of these are statistically significant. In terms of shifting to the ineffective drugs, so AL is the ACT. SP and quinine are 2 drugs that are much less expensive, but also pretty much ineffective due to high rates of drug resistance to these 2 drugs in this area. So we can see it looks like there is some shifting kind of away from the more expensive ACTs and into the cheaper drugs, kind of going along with the idea about, I have malaria, I can't afford the really expensive drug, but at least I can get this cheaper drug, it's better than nothing. But in these cases, it's actually worse than nothing because they're pretty much ineffective and it's a waste of money. Okay, and we wanted to get a sense of how the type of customer changed. So we know that there's going to be some drop out of the market of patients kind of that generally frequent the public sector and are not going to be able to obtain care from the private sector. The public sector, there are kind of long waits that a lot of people are willing to wait in order to not pay out of pocket. And so we see that when there are these stockouts, when the kind of stockout exposure, customers tend to be walking further. So they're kind of having to travel further to get to the private sector facilities. They're less likely to be have low education. So they look like they're actually the customers that go to the private sector are more educated. They have higher income, so kind of $128 per month on average, higher income during this period, and the price that the customers report paying during this period is also kind of 62 cents higher, so quite a bit higher. And so we kind of interpret these results as the idea that there's just less access for poor and educated customers during stockouts, and so that it probably has kind of detrimental effects on health equity. So kind of to sum up, we find that private firms tend to increase their prices in response to public sector stockouts, but their quality is generally unaffected. We think part of this is because it's easier to adjust price than it is to adjust quality, because you have kind of a set inventory, and these stockouts are there's a higher likelihood before the delivery date, but it's difficult to predict whether or not there will actually be a stockout. We find that poor and less educated people drop out of the private sector market, so that the stockouts are going to disproportionately affect them. And so the benefits to improving supply chains are a lot bigger than we would have kind of estimated before. A lot of these studies just look at patients who are being treated in public health facilities and kind of what their outcomes are. But these private sector outcomes are not just for those patients that kind of shifted from public sector to private sector, but also to patients that tend to frequent the private sector, and all of a sudden their prices are going up due to the stockouts. So it's kind of this spillover from private sector to public sector, which I think informs kind of the kind of overall calculus of returns to investment in supply chains. And also that health equity, one of the reasons that these user fees have been reduced and subsidies are available, kind of manufacturer subsidies are available for these drugs, is in order to improve health equity, and so reducing stockouts will also further that goal. Thank you.
All right, thank you, Zoe, for presenting this paper and giving me the opportunity to read it. I really enjoyed it. I thought it was a great paper in a very interesting setting, and I really liked the novel use of data collection and the way that you guys approached the problem. So, just a quick overview: they look at the effect of drug stockouts on prices and qualities of ACTs. They show that private sector customer prices increase during the stockouts in places where they have public facilities. And these affect the lower educated, lower income people to the point where they might be priced out of the market. And it really has nice negative welfare implications of stockouts that haven't really been well studied. And I really liked the objective measurement of price and quality. So using these mystery shoppers, I think, is a very novel and interesting way to get really objective data, which I'm always a big fan of. And I really like the spectrometry. So it's not just the spectrometer data. It was very objective, and I really bought the outcomes. And last, like you said, this is really going to be important to understanding how the private sector responds to changes in markets, and also what we can do to kind of shore that up if we see negative welfare implications to health. So some of the comments that I have are just a few. So the first thing I was looking for when I was reading the paper is just a more precise definition of this binary treatment variable. I wasn't sure if it meant like distance from, like if the date of the visit was further from the date from the last stock delivery to the next, or exactly how was that defined, because I knew it was binary, but I wasn't sure in which way they're categorized. And then I think you presented this well in your presentation. I would love to see the data that you had from 2015 integrated into the paper to really show that stockouts do exist in your setting and that it actually happens along these delivery dates. And so I think you addressed this fairly well, but it'd be great to just really think through how delivery time is determined. So you said it happens 6 times during the year, but does it actually just happen every 2 months like clockwork? Or is it, ex ante decided like a year ahead by some policymaker that says we need to deliver in November and December because we expect malaria to be higher? I know that you said they can't change in response, and I believe that, but it might be good to know how they set that timing. And then natural fluctuations in even perceived malaria incidents can affect demand. I know this happens in Kenya. Sometimes the field officers get sick and all of a sudden they're convinced they have malaria. I was convinced I had malaria for a while, and that could actually affect demand, and so it'd be nice to see that it might not be a concern in your setting. A control for exactly the day of the week or the time of the month might be important at clinics, particularly if the delivery dates coincide with natural dates like Fridays or the end of the month, because you could see private sector people have no reason except just it's the end of the month, I need to make some extra money, so I'm going to raise the prices. It actually has there's no correlation between that and stockout. They just are simultaneously affected by these logistic calendar dates. So if people are targeting a certain income, maybe on a Friday they try to push the prices a little bit higher to make some extra money. And then just the interpretation of your results. When reading the paper, again, I might not be interpreting your tables right, but I just wanted to make sure that sometimes looking at the degree of difference in treatment effect is different than the actual effect on the subgroup that you're looking at. So when I was interpreting your tables, I saw that there are actually decreases in prices during stockouts for areas without public facilities. So I thought that was a really interesting thing. So the prices went down if you didn't have a public facility around this stockout date. And then some of the specifications that you had looked like even in villages with the public facilities, the heterogeneous effect is positive, but the overall effect for that subgroup is still negative. So prices still might have went down, not up during stockouts. So I might be reading the tables wrong, so it'd be good to discuss that interpretation that I saw in your tables. And then finally, the placebo tests that you do, I really like them, but I think that you, again, need to run an F-test or a restricted regression to confirm that the placebo results are not, you don't just want to care about the differential effect, but does the effect exist in your subgroup? And then I was really interested in this and thought about other extensions that you could do, and I thought it was great to put the HHI index in there, but I actually thought that it could be a dimension of heterogeneity. So if we know that prices change during stockouts, those with less competition might be more able to actually change their price. So you imagine there's just a public facility and you're the only private clinic in town, you might have more of a reason or more opportunity to raise your prices in response to a stockout. So I think that would be an interesting dimension of subgroup analysis or heterogeneity. And then again, why the prices go down without public facilities would be just really interesting to understand. It could just be differences in information or context, but it'd be a great thing to kind of dig into, and maybe you have the data for that. Great. Thanks.
Thanks, Jamie. Maybe I'll just quickly address some of those points, because there were a lot of them, and then we'll take questions. Is that okay?
Yeah.
Okay. That was a lot of really useful information. Thank you. So we have controls for seasonality and day of the week in our kind of set of mystery shopper controls. So that's included kind of when the interviews were.
Yeah.
But yeah, I'm sure that wasn't fully clear in the paper. Yeah, we talked about interacting with the HHI, so this index of market concentration. We're concerned that we don't have a big enough sample size for it, but that's something that's on our list of things to do. Whether perceived demand can shift, we think that perceived demand for drugs should be orthogonal to the delivery dates, because I'm not sure people know when those exactly are. So we hope that our identification strategy should sort that out, but I'll think some more about that. And you're right about the decrease in prices where there's no public facilities, and I just need to give that some more thought, so thank you.
Great.
Hi, thanks, very interesting. I had a few questions. One was, do you know what happens when the pharmacy runs out of stock? What do they give instead? Do you have any clue? Like, I guess with the mystery shopping you could, or you would. Do they give, we looked at some of this in Nigeria, but very ad hoc, where clear they give from SP to paracetamol. And so related to that, a gold standard protocol would be that people are tested before they get ACT. So it's not just freely over-the-counter available. And often it happens, is my understanding, that the testing goes on in the pharmacy with an RDT. Do you find stock out of RDTs or other test materials? Or I guess patients don't often come with a doctor's prescription. And how does that affect in a way, the false reports, those who believe they have malaria, but the test shows that they don't or they do? Do the stockout affect these groups differently?
I can do them one at a time. I don't know exactly, when the pharmacy runs out, I mean, they have these different options. They have the ACTs, SP, quinine, paracetamol, anything else they can diagnose it as anything. A lot of the diagnostics would go on in the pharmacy itself. So I don't know exactly, but I think with our evidence, we see there is some shift from the ACTs to SP and quinines. It's probably going to be the majority of the shifts, and I don't think we have a big enough sample to kind of look at any of the other possibilities, but we do have data on that. We know we got the actual drugs that they were given. Compliance with RDTs and doing diagnostics before giving malaria medication is really poor, especially here. And with high rates of malaria, there's a lot of just presumptive treatment. So we do have some data on diagnostics, but it was, I think, overall pretty low in our sample.
Do your outcome data allow you to look at a more granular event study to see if there's any intertemporal substitution or other interesting dynamics in adjustments around delivery dates?
I'm not sure exactly what you're asking.
So you have an event study design essentially,
Yeah.
but it's just a before, after.
Yeah. Oh, you mean looking at the actual time pattern of our
Exactly.
outcomes? Yeah, we've looked at that. We don't have a huge sample, so I think we see very similar patterns. But yeah, we haven't reported those results. But yeah, the patterns are pretty similar. Thanks.
Yeah, thank you. So there's one time I visited Uganda, and they told me that they have two systems of drug supply. One is called demand pull, and the other one is supply push. The demand pool is for certain, usually smaller facilities. They call them level 3 and downwards. And then level 4, they have what they call the supply pool, which is basically the health facility request what they want and the quantity. I wonder whether you are seeing any heterogeneity depends on the type of facility, the levels facility of the public or the level of the public facility, or the small one or the bigger one. Another one is, I wonder, so the stockouts, is it because there's no enough drugs, or the drugs goes to the private? Like, there are these cases where public, staff in the public facilities sell drugs, or somehow drugs end up in private facilities, and I'm not sure that's the mechanism. One of the things I've seen in Uganda they are trying to label the package of the medicine, and even the tablet. Sometimes it might be written UG. That means it's actually a government drug, shouldn't be sold, but it's not uncommon to find those in private facilities sometimes. So I wonder what's going on.
Yeah, thanks. Those are two great comments. We should look at whether the type of public health facility affects this. My understanding is that the facilities in our sample are primarily supply push, and the facilities do tell the central warehouse kind of what they're stocked out of. But even if they're stocked out early and they don't get the delivery sooner, but they get to kind of specify what's in the delivery. So it's still going to be kind of stockouts before, even if they're aware of it. The deliveries just can't come early. They're on the set schedule. In terms of the diverted drugs, we actually have measures of that because that's part of, we actually did the mystery shoppers, we could see. And diverted drugs tends to happen right after the shipment. So the shipment comes in and that's when a lot of the drugs are diverted and show up in the private sector. By the time it's kind of the 2 months along nearing to the kind of next shipment and you have a stock out in the public sector, you see very few diverted drugs in the private sector. They've also been sold as well. So kind of both places are stocked out. So it's not a situation where the private sector hoards these drugs and they're more available when they're stockouts. Great. Thanks, everybody. Great comments.
right, welcome everyone. The paper that I'm going to present today is really a survey method paper, and it's still work in progress, so I'd appreciate all your comments. The motivation for this paper comes from the following. So if you want to know something about someone's true health status, self-reported health measures are not really a good reflection of that. So this is why biomedical testing is done during surveys. But if you do a rapid biomedical test, because of ethical reasons, you have to tell the respondent what the result is, and if the result is actually detrimental for their health, you have to also tell them that they should seek healthcare. Now, this could change someone's healthcare seeking behavior and make your sample not representative anymore of the whole population. Plus, it can also bias impact estimates of related healthcare interventions, such as health insurance. So for this reason, I somehow defined this test effect, which is basically the mechanism where disclosing previously unknown information about someone's health status closes an information gap for that person. So by raising awareness of their true health, they act on that. Now, in the literature, there are several survey effects described, such as the Hawthorne and the John Henry effect, which is basically that the treatment and the control group of an intervention change their behavior because they're being observed. The question behavior effect happens when you ask questions about someone's future behavior and they change that behavior as a consequence. And the survey effect is when you ask questions that give a salience shock, such as questions on savings behavior. So the test effect is really different because you give something tailored information. Now, there is some research in the literature on how biomedical testing can change behavior. So for example, HIV testing, papers by Gong and Thornton, for example, and also in the case of water quality testing, which I think also has a similar mechanism. There's a nice paper by, I think, Jalen and Somatan in the Journal of Development Economics. But these papers, they do not have rapid tests, so they really choose to provide this information. So it's not something that is not wanted, let's say. Plus, they don't look at possible biases of other healthcare interventions. And these are things that I can identify. In my paper, in the case of blood pressure measurements, where the test experiment is overlaid by a health insurance intervention impact evaluation. Now, the research population is located on the slopes of the Kilimanjaro in Tanzania. Almost everyone is from the Chaga tribe, but they do speak Swahili, and almost everyone is Christian. We look at small-scale coffee farmers who are members of actually the oldest coffee cooperative in Tanzania, the Kilimanjaro Native Cooperative Union, or KNCU. Now, not everyone is a part of KNCU. Approximately 40% of households can be called KNCU households, so they have at least one person who's a member. And KNCU is organized in smaller geographical groups called primary societies, and there are approximately 90 of those spread out over the area. The population is relatively poor, with median daily per capita consumption of less than $2. And interestingly, at baseline already 11% had health insurance. 9% was insured by the National Health Insurance Fund, which is the government insurance. So people who work for the government, they can get themselves and their family insured for free. And the Community Health Fund, only 2% were insured by that. So that is a quite cheap public health insurance, but in practice doesn't work as well as it should on paper. Interestingly, there are also relatively few working age individuals, as you can see from this age pyramid. So there are a lot of elderly people and a lot of children. Now let me tell you something about the health insurance intervention. So that's, the insurance is called the Keynes-U health plan, and it's on the one side a demand-side intervention, because it's voluntary health insurance, and on the other side it's a supply-side intervention, because the health facilities where people can go to are upgraded. And these are mostly faith-based or private dispensaries, and a dispensary in Tanzania is like a clinic. Now, this is funded and implemented by two Dutch NGOs. And notably, the insurance includes hypertension treatment. And also, the other two insurances that I mentioned also cover hypertension treatment, at least on paper. Furthermore, the enrollment is on a household level, so not individual level. That would be important to remember. The annual premium is approximately 1 week of baseline median per capita consumption, but it's subsidized, so people pay either 12,000 or 4,500 per person, but it depends on household size, so it's like a sliding scale pricing scheme. The payment is in cash and upfront. And this insurance was introduced to the treatment group of our impact evaluation 7 months after the baseline survey. And right now, the Keynes-U Health Plan is actually joined with CHF in a public-private partnership with the local government, and is now called the Improved Community Health Fund, and is now also available to everyone in the district, so not only the Keynes-U farmers and their families. The experimental design. So there are two interventions. On the one side, the insurance intervention, for which we have like an intervention group and a control group, which is chosen by matching the primary society, so those are the units of the coffee cooperative, on observed characteristics such as whether they have health facilities, which type of coffee the farmers grow, the altitude, which can also be important, and distance to Moshi town, which is the town nearby. The baseline survey was conducted in the first quarter of 2013 with a computer-based questionnaire in Swahili, and it included socioeconomic as well as health-related questions. Now, these health-related questions were only asked, or this data was only collected, if the person gave consent. So this will be good to remember. This was, of course, and in the treatment group and in the control group. We have a random sample of 1,000 Keynes-U households, split 50-50 between the insurance treatment and the intervention group. And the test experiments, so the blood pressure measurements, were done in 80% of all households, randomly chosen and stratified by sub-village. So these are the two separate interventions. The follow-up survey was done 2 years later, in March of last year. And of course, we have ethical clearance. So the blood pressure measurements, which were done at baseline, they were done, so all consenting adults in the 80% of in those selected households were eligible. And there were approximately 3, or on average 3 adults per household. Now, the blood pressure was measured 3 times by a survey medical officer who was dressed in a white coat. It's a signal, let's say, professionalism. And after these measurements, of course, the respondent was informed of the result, which was either normal blood pressure or high blood pressure. And in that case, in case of high blood pressure, the medical officer warned the person of the cardiovascular risk of high blood pressure and advised them to seek health care. And the leaflet that was used for this, you can see here, is in Swahili. This is a picture of where the intervention and control areas are located. The green in the map is actually the Kilimanjaro National Park. The suns are the treatment villages, and the coffees are the control villages. Now, what I forgot to tell you is that originally we had actually 1,500 households in the sample, but because on the east side of the map, the Shimbi primary society they couldn't get the Kensu health plan for political reasons. So those 500 households on the east side fell out of the sample, and finally this is the area that is in the follow-up survey. So at baseline, as I told you, people had to consent for these health questions and also blood pressure measurements. 85% consented, both in the test and the non-test group, and approximately a third of everyone who was tested had high blood pressure. And there were only a few who gave consent who didn't get tested in the test assignment group. Now, at follow-up, there was some attrition, which was, of course, selective, especially the younger people had moved out, but at least it's balanced between the treatment and the control group. And again, approximately 85% consented. And then we end up with a panel of approximately 1,500 individuals. This is of course, the balancing table, which looks fine, except for age. So you can see that the control group in the blood pressure experiment, they're on average older than the treatment group, which may be problematic because actually hypertension risk rises with age. So we have to control for that. And we'll do that by looking in the robustness check to what happens when you reweigh by age. And let me also show you the balancing table between the insurance intervention and control area. And this also looks okay, except for, well, we were, at least it seems, unlucky in terms of high blood pressure measurement, because in the control area of the insurance treatment, more people had this high blood pressure. But because we can include this in the regression directly, it's not such a big problem. So looking at self-reported hypertension, which is an indication of whether the mechanism is there, right? People who, so in the insurance intervention area, which is on the left side, you see that people who had high blood pressure at baseline, they increase their self-reporting of hypertension, and the one with normal blood pressure, they decrease the self-reporting, which is good. So this means that the blood pressure measurement is really doing what you would expect ex ante. The control group is right between the two, the high and the normal blood pressure. And you see that in the insurance control area, it looks quite similar. Whether someone consulted a healthcare provider for hypertension in the past 12 months, that also looks very, very similar. So you see again a reaction to the blood pressure measurement. And notably, it looks similar between between the insurance intervention and the control area, which could be an indication that there is no difference between the two. But we'll see in the regressions. Insurance. So as I said already at baseline, 11% of individuals were insured. You see in the insurance intervention area, all three groups have a rise in percentage insured. But in the insurance intervention area, it seems constant, except in 2015, where for some reason they got more of the CHF insurance. But in the insurance control area, no one got the KNCU health plan insurance, which is good. So we look at the individual fixed effects model, where the MI is the blood pressure test assignment dummy, and DI is the insurance intervention area dummy. And the interaction between the two, so that's the second term that gives the bias of the measurement of the blood pressure measurement in the insurance impact results. And additionally, we look at the split when you split the blood pressure measurement into normal blood pressure and high blood pressure, and what happens then. All right, so let me first show you the table for looking at blood pressure measurement, not differentiating by result, and you see actually nothing, and also not in the interaction term. But when you split it up into normal and high blood pressure, then you see that really it's the people with high blood pressure at baseline who react. So they self-report significantly more to have hypertension, and there's a 12 percentage point increase in consultation for hypertension in the past 12 months. But there's actually no effect on insurance. And the normal blood pressure does nothing, as you can see. When looking at the interaction effect with insurance area, again, there's nothing. So, meaning that there's actually no bias from the blood pressure measurement. Now you can wonder, is there a difference by prior beliefs? So when people at baseline say that they have hypertension, maybe they react differently to the information that you give them. But actually we don't see any heterogeneity by self-reported hypertension. So there was one additional outcome variable in the paper that I didn't discuss right now, which is having your blood pressure checked in the past 12 months. And actually we didn't see any effect for that. And this might be because maybe you didn't go to the doctor because of hypertension, but for other reasons, and your blood pressure was checked because of that. And the results are robust to a different clustering of standard errors, and actually also with this age group reweighing. So in conclusion, measuring high blood pressure during the baseline survey increased healthcare use for hypertension, but didn't increase health insurance uptake. And the two potential explanations being that actually the KNCU health plan is a household level insurance and not an individual insurance, which reduces the self-selection. And maybe because it was offered 7 months after the baseline survey, that people didn't really connect it with the blood pressure measurement. All right, thank you very much.
Thanks, Zlata. I enjoyed reading the paper. I think there's a lot of interesting things in here, so I'm going to talk a little about kind of teasing those out. So I won't summarize the paper because you just sat through it, but thinking about this kind of test effect bias and thinking about how concerned we should be. And I think, I was surprised that this is really the first paper that gets at this question. I think it's really important for survey methodology, especially for these kind of longer panels where you might be not just doing kind of the test once, but over time that could really change people's behavior. So in your study, you found that the kind of bad blood pressure result was actually canceled out from the bias from the good result. So it actually ended up being no overall bias. So kind of that's the straw man here. I think we should, of course, be concerned about the bias, but if it just looks like it's being kind of canceled out in both directions, then we can be less concerned. So thinking a little bit more about how to kind of couch this and motivate your paper about why we should be concerned about it in general, even though you don't actually show that it would influence your results very much in this particular study. You were just really unlucky with your sample imbalance. It was, that's really tough. So, but I think you were able to address it pretty well. Having the individual fixed effects is really helpful, and then doing the age group re-rating I think was a good way to go. It'd be great if you would show the results and the methods in your study, because just to kind of a reader is going to want to double check that they agree with the methodology, but I agree that that was the way to go. You found that there was no effect of having this blood pressure test result on enrollment in health insurance. And I think that's based on this kind of idea that we think, okay, well, you have high blood pressure, it means your health isn't very good, therefore you're going to want health insurance in order to get medical care. And I wonder with this whether kind of our theoretical model actually applies and whether this population is thinking things through kind of in that way. They may not associate high blood pressure with poor health or associate it with something that would need a fair amount of medical care, and so they might not make that link. And I think it'd be worth talking about kind of you talk about some of the factors within your model that would influence this, so thinking about kind of other factors about kind of affordability and whether people make the connection of kind of what health insurance is for. Channing's paper, he found that he gave people health insurance for a year, and then the next year they didn't buy health insurance again. So maybe people they either kind of underestimate the benefits or it's not actually actuarially fair. So just thinking about some of the other reasons why there might have been part of that theoretical connection, but these barriers that prevented you from seeing it in your data. And then I think the big picture is thinking about kind of how important is this blood pressure information. From our point of view, you might think, oh, this is really important health information, but from their point of view, they might not see it that way. And so thinking, well, how many of their day-to-day decisions or decisions about health-seeking behavior are actually made based on their blood pressure? And so how much room is there actually for this new information to change their decision-making process? And I think the other question is, well, how unexpected were their blood pressure results? So the Gong paper, which is also really nice, looks at, for those of you who aren't familiar with it, looks at kind of people getting information about their HIV status, and finds that when people are surprised by that information, that's when their behavior changes a lot. They assume they're HIV positive, find out that they've been making the kind of correct decisions all along, but if they find out all of a sudden they're actually negative, then they're going to change their behavior. And so thinking about, for most people, do they have a sense of what their blood pressure is or not? You have some data on that, but thinking about how much of an information shock is this? And so it may be for some people that, and this is kind of the convoluted question about how much new information is it, how many decisions are made using that information, and therefore how much does the new information change behavior that we observe. But I was thinking a little bit about the data that you do have. So blood pressure measurements have this really nice arbitrary cutoff. You're above a certain cutoff threshold, you have high blood pressure, and you get the brochure, and below that you get nothing. So there'll be a lot of people who have very similar blood pressure but get very different information. And so this is actually not kind of what you've been going at with your paper, but I think this might be another way to get at some of these questions. I don't know whether you actually have the result, but they took 3 blood pressure measurements. So you actually have a number of different ways to measure this kind of RD cutoff. And so if you have information on those 3 different measurements, thinking about people who would otherwise be the same, but they just end up being randomly on one side or the other. And so you can really think about the effect of information on the margin. 2 people who are otherwise look the same, maybe they both control for, they both thought they had blood pressure in the past, and one of them finds that they still have high blood pressure, and one of them finds that their blood pressure is normal and how that influences their behavior. That would add another really interesting layer to what I think is a really interesting paper. And I would suggest, this is, I think, a really important question, and it'd be great to look at this with other data sets. So I kind of encourage you or other people in the audience to kind of take this question and run with it, because I don't think we think enough about how much our measurements actually are treatment. And that's a kind of a bigger, important question for everyone to think about. Thanks.
Let me say thank you very much, Zoe, and especially the comments of the margin, looking at the yeah, I think that would be extremely interesting. Thanks a lot. Anyone else? No one? Okay. Then this is it. Thank you. Thank you very much.